All right, so let's look at hypoglycemia a little bit more. Seizures are a possibility here, and that should be considered very serious. This could indicate a potentially life-threatening underlying condition. As we talked about in the neurologic chapter, as far as management of any type of seizures, we really just want to make sure that the patient is safe, that we remove them from anything that's going to be a hazard to them with the movement, that we don't hold them down, we're not putting anything in their mouth, definitely not oral glucose, and we're calling for ALS here to help us manage that seizure with medication, and again, if hypoglycemia is the reason, with IV dextrose. The altered mental status may be caused by other conditions, so we don't want to rule that out. We want to make sure that we are taking a look here at all potential other underlying conditions, treating what we can to help rule some of that out. We want to look at misdiagnosis of neurologic dysfunction. So we never want to just assume that the patient is intoxicated. And we might get called to a lot of scenes throughout our career where a patient was assumed to be intoxicated by law enforcement, but hey, they just wanted us to check them out before they've already arrested them, but they want us to check him out before they take him into the jail. And we wind up finding that the patient is not intoxicated, that they actually have a too low or maybe too high blood sugar. So we want to make sure that we're doing a thorough assessment here and not just assuming that. If the patient is just assumed to be intoxicated and they unfortunately have a low blood sugar and they're put in the jail cell, they could die. So a lot of times law enforcement officers are taking the opportunity to have patients checked out by EMS for a variety of reasons to just rule all of these potential things out before taking them to jail. And so that's a huge step on their part to, again, do the right thing by the patient. So make sure that there's nothing else going on rather than just assuming that they are intoxicated. We want to look for, again, any of that emergency medical identification, whether that is bracelets, if it's something in their cell phone that's indicating that they're diabetic. We can perform a blood glucose test at the scene, and we can look for any type of other signs that are there as far as a patient being a diabetic. We do know that patients can be diabetic and also have drink alcohol or be an alcoholic. So yes, these things can coexist. So it's not just one or the other. They could definitely have a low blood sugar and still be intoxicated. But we want to rule some of those things out. Looking at the relationship to airway management, patients who have hypoglycemia may not have a gag reflex just because once the brain is not getting the oxygen that it needs and it's not working properly, that may be one of the first things to go, which could be a real concern if the patient begins to vomit and they're unable to protect their own airway. So we want to carefully monitor that. If the patient is vomiting, we can put them in a recovery or a left lateral recumbent position to help maintain some of that and make sure that our suction is available whenever we need it. So moving on from here, let's look at some hematologic emergencies. So hematology is the study of blood-related diseases, and there are three real pre-hospital emergency things that we need to consider, and that's sickle cell disease, hemophilia A, and thrombophilia. So we've talked about blood many times before and kind of what it's comprised of. We know we have the red blood cells or erythrocytes. The main function here is the hemoglobin that carries oxygen to tissues. Our white blood cells are leukocytes, which respond to infections and help to keep the body safe and healthy. Our platelets, which assist in clot formation, and our plasma, which is the transportation medium or the liquid portion of blood. Now, looking at some of these disorders, we have sickle cell disease, which is an inherited disorder that affects the red blood cells. It's predominantly found in people of African, Caribbean, and South American ancestry, but that does not say that it can be limited to those. People with sickle cell disease have a misshapen red blood cells that lead to dysfunction in oxygen binding and unintentional clot formation. So if we imagine that our red blood cells are normally all round discs, and suddenly we have some that are more crescent shaped. First of all, if it's crescent shaped, it's not going to be able to carry oxygen like a completely round one would. It's essentially cutting that in half. And so we've got a lot of oxygen issues here. We're starting to have anemia. We're starting to have hypoxia. We're starting to get blood clots because these crescent-shaped cells are catching each other and hooking together and forming clots where they shouldn't, and they're getting lodged in places that they shouldn't. So these clots can result in a blockage known as a vaso-occlusive crisis that can result in hypoxia, pain, and potentially organ damage. And so this can happen in any organ. These sickled cells have a shorter lifespan than a traditional red blood cell, and it results in more cellular waste products that contribute to a slowing down process or a sludging of the blood. And some of these complications can include anemia, gallstones, jaundice, which is liver dysfunction, splenic dysfunction in the kidneys, or vascular occlusion with ischemia past that point. So it kind of functions just like any other blood clot or plaque would, in that it's not preventing, it's preventing blood flow past that point, leading to ischemia, and that could be of any organ. Many of these complications are very painful for the patient and potentially life-threatening. Now, thinking about treatment for that, and we'll get into some of that a little bit more, but sickle cell treatment, there's not a lot that we can do in a pre-hospital setting. Pain management, oxygen administration if the patient is having shortness of breath, but really there's not too much that we can do. Clotting disorders like hemophilia, this is fairly rare, and only about 20,000 Americans have this. It affects mostly males. They have the decreased ability to create a clot after an injury, which can definitely be life-threatening. These patients usually have intravenous factor VIII replacement infusions, which help the blood clot close at hand. So this might be something that they receive daily, weekly. They might go to a facility to get it. They might take it at home. Just kind of depends on the severity of their condition. Now, thrombophilia, this disorder is the body's ability to maintain the smooth flow of blood through the venous and arterial systems, and a concentration of particular elements in the blood creates a clogging or blocking issues. So again, the body is just creating more clots than normal. The patient is really prone to clots, and these clots can spontaneously develop in the blood of a patient anywhere. So when we start thinking about someone who is more prone to having blood clots, we usually think about someone who has this type of clotting disorder, someone who takes blood thinning medications on a regular basis, someone who lives a sedentary lifestyle, like they're wheelchair bound or bedridden, they sit at a desk all day, maybe truck drivers, someone who's had a recent surgery, and females in childbearing age who take birth control pills. So all of those are risk factors, and it doesn't necessarily mean that they are going to develop thrombophilia, but it does make them more at risk. Now, other clotting disorders can be deep vein thrombosis or DVTs, which is a common medical problem, more prone in those sedentary patients that we discussed or who've had a recent injury or surgery. And essentially these deep, thrombosis are just developing in those vessels. And so these patients might take blood thinning medications, use compression stockings, or the mechanical devices to help alleviate this. So if you've seen someone in a hospital setting, pre or post surgery, who've been in, bedridden, and they have those stockings on that consistently they inflate and then they deflate, and they inflate and then they deflate. Those are the mechanical devices that are helping to prevent blood clot formation. Oral medications can be used. Some of these medications are also injectable, and so I'll use myself for example. I have had pulmonary embolism previously when I was 16 years old from birth control pills, and also in my second pregnancy. And so I had to utilize in both of those instances, and during my first pregnancy as well, injectable medications for blood thinners, and I had to do that my entire pregnancy and 6 weeks after delivery, just to kind of wean myself off. So those are some of the things that someone might be utilizing on a short-term or long-term basis, but they can also take oral medications as well. So a clot from these deep veins can travel from the patient's lower extremity up to the lung, causing that pulmonary embolus. It could travel to the heart, causing an MI. It could travel to the brain, causing a stroke. So it can lead to more serious conditions. Things we want to consider as far as scene safety. A lot of these patients will know that they have these conditions. They probably had them before. We want to wear gloves at a minimum, maybe eye protection if we're managing the airway. And we can consider ALS support for a number of these, as it's going to be more than what we can handle at the EMT level, but usually not a lot even at the ALS level that can be done in the pre-hospital world for any of these conditions. We want to perform cervical spine immobilization if necessary, if we consider that, or excuse me, if we assume that there are any spinal precautions that need to be taken because of potential for trauma. We're going to get our general impression. We're going to look at our airway and breathing. We're going to administer oxygen when we need to. Specifically to our sickle cell patients, they may have increased respirations or signs of pneumonia, and they might need more oxygen just because of their inability to carry that oxygen that's there. So we really want to get them as much as we can. Other things to consider, specifically with hemophilia, looking for acute signs of blood loss. Remember that any injury, no matter how small, can be potentially life-threatening for them, so that's a major concern. And just due to that blood loss, they could also be hypoxic. We want to transport patient to the ED, usually of their choice, maybe where they receive specific treatment or where their doctor is familiar with their condition, or if this is a true emergency related to like severe blood loss because of trauma, maybe to a trauma center. We want to ask questions about their chief complaint as well as their history, getting any type of medications that they take, asking about their pain. Is it isolated to a single body part or felt throughout the body? Are they experiencing any visual disturbances, nausea, vomiting, abdominal cramping, chest pain, or shortness of breath? We're going to ask more questions like, have you ever had this happen before? If you have, when was the last time that you experienced a crisis? And how did it resolve? Last time, were you sent home on a new medication? Were you in ICU? Were they on a ventilator? How long did that last crisis last? And then have they had any recent illness, unusual amount of activity, or stress that could be affecting these things as well? We want to focus our examination on joints, especially where for our sickle cell patients where there could be increased swelling or potential for blood clots there. We want to evaluate and document the mental status, looking for AVPU. We're going to get a full set of vital signs. Again, are they having a decrease in their SpO2? Are they having an increase in their heart rate? Are there changes in their blood pressure? Remembering that trending vital signs are more important than just getting one set that may appear negative. We're going to frequently reassess 15 minutes for stable patients and every 5 minutes at least for patients who are considered unstable, administering oxygen whenever we need to, and communicating with the hospital staff and giving them a clear report of what's happening, and then following up with documentation of all of this. As far as emergency medical care for our hematologic disorders, again, like I said, there's not a lot that we can do. Our care is mainly supportive and symptomatic, meaning that we're treating the symptoms that we see. If the patient is experiencing pain significantly or nausea, we could consider calling ALS for treatment with that. Otherwise, placing the patient in a position of comfort and providing rapid transport to the hospital. So that's going to wrap up this chapter. Hopefully this has been helpful to you guys. If you do have any questions about this chapter or any other, please feel free to reach out to me with any questions that you have, and I will catch you guys in the next video.